Right, we're live. Good. That is good that we're live. I'm completely and utterly ready for this, and I am hoping that everything's okay and working. Tuesday night, 7 o'clock, at least I'm pretty sure it is, which can only mean one thing, and that is the Q&A that is known as hashtag Ask JJ, myself being JJ, and I'm live on Facebook. Oh God, have I pressed the button? And also, and also on Linktogram, as I like to call it, Instagram, as others call it. And good evening. I've got some questions here. So I am going to kick off with one, which is a tattoo. And I'm always very grateful to patients allowing me to show photos, because I do think it does jazz it up a bit. So I've got hi Corinne, good to see you. I've got a photo which I should know what button to press by now. That's the button, which is a tattoo on a wrist. And this is a patient who has contacted me. They've had several episodes of laser. Usually I would recommend laser as a first line for tattoo removal, and then consider surgical excision, which is what we do at the clinic. But this one, there's two aspects to a hi Corinne, very well, thank you. There's two aspects to a tattoo in terms of whether it's suitable for excision, and those are the size and the location. When I say the size, it's not the absolute size, it's really the shortest diameter. So kind of quite a big, long, thin one would be suitable. So it's the shortest diameter that's important. This one is kind of like a round shape, so there is no kind of short diameter. I hope I'm making sense here. So kind of like an oblong shape would be better than a round shape. A round shape is pretty much the worst shape you can have, because I've got to think, what sort of orientation can I close this in if I'm going to excise it in order to get the minimum tension on the wound. And really, as I say, it's sort of like a round, so I haven't really got any options in terms of having a narrower closure. So the shape isn't great, the size is pretty big, and the location also, I'm sorry to say, is not great. There isn't a huge amount of spare skin in the wrist area. You might say, oh, there's quite a lot there, but you've got to remember, you've got to move the wrist, and pretty much all that we would call it the volar surface, all of that sort of surface of the wrist is involved with that tattoo. So you're not really, the way that I remove them is by excision. I don't do skin grafts. So if you're not going to do a skin graft, then you've got to think, how am I going to get this piece of skin to this piece of skin? How am I going to get that closed? And even with serial excision, even with kind of like multiple excisions, I really think that I just don't think that's gonna be able to be closed. So I don't. It's not a good tattoo for excision. I am sorry to say, I feel bad, but because you got in touch and you kind of want me to help you, but it's not. If it is any consolation, I would say 80, maybe not, well, maybe 90% of the tattoos that we get sent, we can't help with, for one reason or another. Size and location, those are the one reasons, and the others. So the majority of tattoos are not suitable, either because they're too big, or if they're not big, then they're in a bad location. So this is not going to be a great one. It's not going to be a goer for excision. And personally, I don't do skin grafts for tattoos. I don't like it. I don't like the cosmetic effect of a skin graft. Doesn't look good at all, and particularly in this area. Before you say anything, if you're thinking skin graft might be an option, it's just not good, because you've got your wrist flexors, the tendons, and that you move your wrist and your fingers. So it's just not good. You don't really want to run the risk of getting them tethered onto the skin graft. So skin graft's not an option, and I'm sorry to say that I don't think excision is an option either. So, and I know this patient has tried, I think, multiple laser. So that, I'm not sure where that leaves us really. Cosmetic makeup, maybe, but that would only be on certain occasions. It wouldn't be a permanent solution. So, yeah. But thanks very much for letting me share the photo. Very grateful for that. Not sure how to get it off now. Stop sharing. Yeah. So what else we got? We have got. Is this? Yeah, I believe my boobs would have been called tubularity. Cone-shaped breasts with puffy, swollen nipples and protruding areola areas. I went to Harley Street, had an areola reduction and implants put in. I think I must have been allergic to the stitches. The scars under the breast healed, but around the nipples the stitches wouldn't dissolve and had an infection that lasted about a year on and off. The nipples still stretched back out, and they did attempt again not long after, but they still stretched back out. I'm still conscious of my nipples and find the scar tissue sometimes shows when I'm wearing clothes. Do you think it would work to try again? I'd like to change the implants anyway, but it would be amazing if I could reduce the size of my nipples too. So it sounds like what's happened is you've obviously had a problem with your scar around your areola. So the problem with tubular or tuberous breast is that the areola is often enlarged and herniated, kind of protruding, which is what you're describing. And the first thing is tuberous breast deformity is a difficult problem to correct. And it's difficult when this is all I've got to go on. It had it when I was 19. I'm now 38. Okay, so it's difficult when this is all I've got to go on because I don't know what was done, how it was done, but I'm going to guess here that the areola reduction was done with a permanent suture, because if you're saying you've had an infection that lasted about a year on and off, that's quite uncommon, and it says to me that maybe there was a permanent suture in there, because if there's infection around a permanent suture, that is not going to settle unless you remove that permanent suture, because the permanent suture is a foreign body in the same way that an implant is a foreign body. And if you get an infection with an implant, you have to remove the implant. Well, it's the same if you're using a permanent suture around the nipple and you get a infection around it. You're in a difficult position there, because what do? Do you remove the permanent suture in order for that infection to settle, but then your nipple will enlarge again, or do you ride it through and hope that you can treat the infection with antibiotics and try and maintain some cosmetic benefit from the stitch, which is trying to keep the areola closed? It sounds like it's kind of settled, and you've still got a stitch in, you've still got a stitch in there, because you don't say that a stitch was removed or anything, but you're saying it's still stretched back out, which is always a risk with areola reduction. It can stretch back out. And the scar tissue sometimes shows. I mean, again, hard to say without seeing you. I think it's good that you've left a long time, if that's right. If you were 19 when it was done and you're now 38, it will be nice to see what the scars look like and what the areola looks like, to see whether it would be possible. But in principle, it's always possible to redo the areola reduction. That's always possible. Of course, it will give you a fresh scar, and you have had a problem. There is no guarantee you wouldn't get another problem, so you would have to kind of be pretty confident that you were okay taking on the risk of potentially having another problem. And I always say to patients who've had problems, it's like, I can guarantee you won't get another problem if you don't have any more surgery. It doesn't sound very good, does it, for a surgeon to be saying that? But you kind of feel like you need to be aware that there's always risks of problems, particularly when you're operating on areas that have been operated on before, because you're dealing with scar tissue, and so there's a risk that things might not heal up as well, and you could get further problems. And do you really want to go through that? Because let's face it, it's traumatic when you've got problems, and you don't want to you don't want to go through more problems. So you have to kind of think about whether it's worth it. in terms of the benefit, because if you did have another areola reduction, there is a risk you could get the same problem. The areola stretching out is less of a risk if you have a permanent suture, so that, you know, it would be nice to know whether it was a permanent suture or not that you had there, because if it wasn't, then I'd be more confident that potentially giving you a more long-lasting result. But as I said earlier, the fact you had problems for a year suggests it was. So if you've had it stretch out and it was already a permanent suture that you had used first time, I'd be like, ooh, is that is it worth trying again? So it's difficult, and I guess it depends on how bad your scars are, because they're very old now, the scars. So I hope they've faded quite well. But if the scars are still looking bad, your areola is still too big, on paper, yes, it would be possible to do it again, but you'd have to be aware that there's a potential for complications again. Although obviously, anytime we embark on surgery, we are hoping it will not have another. You will not have another problem. So we've got to go in with a positive mindset, but there's a risk that it could be you know, you've got to be realistic about the potential risks. Would you perform surgery on someone with factor V Leiden if they've previously had a blood clot in each lung after previous surgery? Well, it's always difficult giving a kind of set answer for this, because the thing about surgery is you've got to weigh up the risks and the benefits. So you've got to weigh up the risks of not doing surgery and doing surgery. So and a lot of that weighing of that risk comes down to the patient as to the reason they're having surgery. So it depends on what surgery you're thinking of doing to them. So obviously, if you're thinking of doing an appendectomy where they could die if you don't do it, the risk is very heavily in favor of doing further surgery. Whereas if you're doing something, maybe a cosmetic procedure, particularly if they're not particularly, you know, if it's just nice to have that cosmetic procedure, but they're not, you know, particularly concerned about that, then might be thinking, hold on a minute, you know, you've got to be careful. Factor V Leiden does increase your risks, and you previously had a blood clot in each lung. My gut feeling is that would be one that I probably would say to you, don't have another operation. Of course, it depends what it is. If it's a mole removal, yes, okay. But another operation that's got you know, another risk of having DVTs or blood clots, PEs, blood clots in your lung. So if it was another operation that had a potential risk of further blood clots, I would probably say, if you've previously had a blood clot in each lung, my advice would be to not have further surgery, although I'm very happy to discuss it with you. And if you did push it through, you'd have to get the approval of an anaesthetist hospital, and I think that would be difficult based on that basis. I think the risks would be deemed probably. I don't want to speak for them, but I wouldn't be surprised if they would take you on in terms of the hospitals and the anaesthetist. But as I say, even with a discussion with me, I'd probably be steering you away from having further surgery and suggesting you're better off quitting where you are, perhaps. I'm considering having my implants removed. Would lifting the breast be a part of this procedure? No, it would not. And the other thing to be aware of, if you are going to have your implants removed and you're in that area where potentially lifting the breasts is a thing, that you think there might be a bit of a droop to your breasts, actually removing your implants is going to make that droop worse. So you would have to be aware of that and be prepared for that. It would be possible to lift the breasts at the time of removing the implants, but that would have to be explicitly said and explicitly consented for and explicitly discussed with you, because of scarring, risks of complications, etc., with a breast lift. So personally, I normally tell people to, well, like I said, it depends on how bad you think it's going to look when you have the implants removed. You're never quite sure, but if you think, crikey, that's, you really, if you're not happy with the shape now, you're going to be even less happy with the shape when the implants are removed, because the implants will have stretched the skin to a degree. But if you're kind of okay with the shape now and you think, I might be okay with the shape when the implants are removed, there's something to be said for seeing what it looks like, and then you could always have a lift later. Obviously, means 2 operations, but it's another one for discussion, really. Discussion with the patient, make a plan between us, try and do what's right for you. If I wanted my implants only removed because they're too big and heavy now, would the capsule also be removed even if there's no sign of capsular contraction? No, they would not. So implants have been in for 11 years. No, they would not. So if you're having the implants removed and not replaced, you would not need to have the capsule removed. If you're having the implants replaced, then we would need to talk about what we do within it, the capsule, because you potentially would remove part or potentially all of the capsule. But if you're not having the implants replaced, there is no need to remove the capsule. We would have a look at it. If there was any concerns about it, if there was a worry about it, then we might remove some or all of it, particularly if there's any worries about it looking abnormal. We could send it in, send it off for histology. But the capsule itself, once the implant has gone, is not a problem. The problem is the combination of the capsule, which is basically scar tissue around the implant, and the implant kind of compressing that implant, making it feel really hard. But once that implant's gone, the capsule kind of is just usually pretty soft. But as I say, if there's any abnormal areas, or if it's sometimes it can be like calcified, like really rock hard, so probably remove those areas. But in general terms, I wouldn't be looking to do anything significant in terms of removing the capsule if I'm just removing implants, which does significantly simplify the operation in terms of the time of the procedure and the risks of the procedure. The risks are increased when you start doing stuff to the capsule, like removing parts of the capsule, particularly in terms of bleeding and swelling is increased when you do stuff to the capsule. Why is it so important that I give all of my medical history during the initial consultation? Because you're having okay. Well, I'm assuming you're potentially going to have a surgery. So if you're potentially going to have surgery, then we would need to know what. It's a funny question. This we need to know if you're on any medication, which might affect the medication that we use when we're doing the anesthetic. We would need to know if you've got any medical problems which might affect your ability to heal. We need to know if you're on any medication, any medical problems which might affect the medication we give you, stuff like asthma, stuff like indigestion and stomach ulcers. They are made worse by the non-steroidals, ibuprofen and things like that. So some of the drugs we give as painkillers can exacerbate asthma or indigestion. Some patients might be on medication that thin the blood, which would increase your risk of bleeding. Some patients might be on medication that would delay wound healing, things like steroids or immunosuppressants, which would all have an effect on when we weigh up the pros and cons of having surgery to say whether we're going to, whether it's going to be a good thing to do or not. So it's very important that we have as much medical information about you as possible, because you're going to have an operation. So it's kind of what you would expect if you're having any operation. If you're going to have a hernia repair or a stomach removed or a whatever operation you're going to have, you would be expected to talk about if any medical history that you might have, because it might be relevant in different ways. You might have scarring on your abdomen, for instance, if you've had previous abdominal surgery. Admittedly, a lot of things are not that relevant. Things like diabetes, increasing your risk of wound healing problems, and also we'd have to think about your sugar management prior to surgery. So we want to keep you starved for too long. So there's all sorts of medications and illnesses and problems that can affect what we do in terms of the surgery. So the best thing is to tell us everything, and then we can make a judgment. Because I was going to say, there's also an awful lot of things which don't affect the surgery. So you're absolutely right. There might be things that you tell us about that won't be any effect either way. But it's usually best to tell us everything, and then we can say. Sometimes we'll say, "Oh, hold on a minute. You got what? You got indigestion. What was that? You're asthmatic or something." So these things might be relevant. So yeah, it is important to tell us everything. And I wonder why the question's been asked. Is there something that you are concerned about telling us? But I'm guessing you're not going to tell us what that is, because by definition you're concerned about telling us. But anyway, yeah, you should tell us what that is. Yeah, you know what? I just realised. Am I on? Why is it? Oh God. Do you know what? I'm not even sure of how I'm on Facebook. Am I? You know, this thing back in the day was called Facebook Live. Anyway. Okay. Right. Anyway, professional. We'll move on. Okay. We'll assume I'm. Anyway, that's that. So I haven't got any more questions. That's all my questions, Your Honour. If you've got a question, please call me, email me, drop me a line, message me, or whichever your preferred method of contact is. Because I'm going to be back here next week, and God, I need to fill the pot of questions because I don't want to be sitting here with my pen in my hands. Okay, so yeah, next week, same time, same place. I think, pretty sure I'll be. Oh, what? It's a dead wasp. God. Anyway, I'll be here, so I will look forward to. I don't see Facebook. Oh man. I think that's anyway. Okay. Sorry, Corinne. Good. Thanks for checking. I'll get the IT team on it, and we'll. I don't know what we'll do. Anyway. Eek. Anyway, there you go. You'd think I'd know how to get it on Facebook by now, wouldn't you? Okay, I'll have to look at it. Take it easy, Instagram, and also